Hey guys, so today we're going to be talking about eating disorders. Eating disorders are kind of an interesting subject in that while they're very commonplace here in the United States, if we think about them in a global context, we don't actually see them consistently across all countries and nations and cultures. Also, if we approach them historically, we don't really see them uniformly at all points in time either, which begs the question, are eating disorders global universal diagnoses, or are they culture-bound syndromes, much like ataxia nervosa or Kajin-Kifosho? But we simply think of them as being more mainstream because they happen to be more mainstream in our culture. So let's explore some of these scenarios. So historically, some examples of times when eating disorders have been more rampant, at least within particular cultures, are Romans and then kind of Christian devotees. So this would be more around kind of the Greco-Roman age and then a little bit later on in the Middle Ages. So we're talking several hundred years ago. So ancient Romans would sometimes engage in this kind of celebratory type of practice where they would excessively binge eat a lot of really luxurious, rich food at parties. And then in order to continue consuming, there was intentional purging, typically in the form of vomiting, in order for that group of individuals to continue on. And so, what's interesting about this is that we're not talking about all Romans, we're talking about kind of a higher SES type of Roman. So, it's a very particular culture that's kind of breeding this disordered eating behavior. Similarly, several hundred years later during the Middle Ages, it wasn't completely uncommon to see Christian devotees as a means of showing how devoted they were to God to basically starve themselves. Because from their point of view, their soul was what was really valuable, not their physical body. And so, again, to show their devotion, they would intentionally starve themselves to show the lack of importance for the physical body. So, again, a disordered eating behavior that we weren't seeing consistently across time or even consistently within that period of time, but very consistently within this group at that point in time. Today, again, we do see eating disorders. Obviously, they're very prevalent in this country, but we don't really see them universally. For instance, in Fiji, which is an island nation, television really only came to the country in the mid 90s. And some researchers thought it would be interesting to kind of study a before and after, so to speak. And what they were tracking was disordered eating behaviors like induced vomiting, and then other types of disordered eating thoughts, such as viewing oneself as fat. And they observed these characteristics among middle school age girls. And what they saw was that there was an increase with respect to both of these behaviors post exposure to television, which happened to include a strong prevalence of Western media. Another study that's kind of more relevant to the influences of today exposed a group of participants to cosmetic surgery reality TV, which, if you haven't ever consumed that type of media before, it really entails kind of picking the body apart very critically. And research has shown that when you have participants watch this type of media, even if they hadn't watched it before, that after that consumption, there's a decrease with respect to self esteem, suggesting that self esteem may be tied to body image, and that could then potentially lead to disordered eating behaviors. And so the big takeaway from these examples is that it really seems like this Western culture, specifically a culture that perpetuates this thin ideal in women and this muscular ideal in men, may be the modern culture that is eliciting these disordered eating behaviors. More specifically, within that culture, those working in the entertainment industries, which would include celebrities, influencers, and those working in sports industries, particularly sports that either value a very low weight or fluctuating weight, like, for example, dancers or climbers or even kind of wrestlers or fighters. Those are going to be be folks that are at an even higher risk for eating disorders. So at the end of the day, the big takeaway from this slide is that even though eating disorders are fairly mainstream in this culture, they do not exist universally, and so it may be more appropriate to consider them as culture-bound syndromes. Okay, so we've got 3 eating disorders that we're going to be focusing on today, the first of which is anorexia nervosa, or anorexia for short. There are 3 big pieces to this diagnosis, first of which is a restriction of energy intake such that the person gets to a significantly low body weight. Typically, we consider this to be underweight using the BMI scale, which would be a BMI less than 18.5. In this way, anorexia is considered to be a visible eating disorder, in that it's very obvious looking at someone with anorexia that they do in fact have anorexia because of that low body weight. That is something that makes this diagnosis a little bit unique, and you'll see that when we get to bulimia and binge eating, that we see more typical body sizes from those 2 diagnoses, and so it's not quite as obvious per se that something might be wrong with that particular individual. And so because there's a visibility to anorexia that we don't see from some of the other eating disorders, it's pretty common to see more camouflaging types of behaviors where individuals will try to hide the severity of their symptoms with larger jackets and clothing and things of that nature. That stuff, of course, also becomes more necessary at this particular weight because it's not uncommon for these folks to gradually have a more difficult time maintaining their own body temperature. So big takeaways from those couple lines are that this person's limiting their calories, whether that's through exercise or through limited consumption. They're at a low body weight and it's visibly obvious to others. In addition to that, we need to see an intense fear of gaining weight or becoming fat. So this is an important symptom to note here because we have established that this person is at a significantly low dangerous weight. So it doesn't make any sense for this person to fear gaining weight or becoming fat. So that's really kind of what makes this an atypical symptom, is it's the context. Beyond that, we may see the person experiencing their weight or shape as large, and this may cross over into a delusional type of territory, or they may refuse to recognize the seriousness of their low weight. This is one of the symptoms that I feel a lot of lay people don't necessarily associate with anorexia. The fact that these people are so thin to a dangerous point, but they're still looking in the mirror and seeing themselves as overweight, large, fat, excess weight that still needs to be lost. And so there's a very much a delusional quality to this diagnosis. A delusion meaning that a person has this fixed belief that is not in touch with reality. Very similar to what we talked about in our previous unit in terms of going over body dysmorphic disorder. There's several different types of anorexia too. This is another piece that a lot of people don't recognize about the diagnosis, is that there is the restricting type, wherein a person would restrict or limit what they're eating over at least a 3-month period of time in order to hit that low body weight. So that's the one that most people think of, but there is a second type, which is the binge eating purging type, which would basically entail the person combining binge eating with purging, or maybe one or the other, in order to get down to that lower body weight. So one difference between this particular pattern and the pattern that we'll talk about later on in bulimia, which is a binge eating purging type of diagnosis, really has to do with the amount. So someone with anorexia is getting down to that low body weight, which is unique to anorexia. You're not seeing that from bulimia. And so the amount of binge eating in this context is less, the amount of purging is more. And the binge eating in and of itself doesn't really have a definition, which is unique. You'll see that we're going to define what binge eating is later on in talking about bulimia. And so that kind of leaves the door open here in this scenario that the binge eating could potentially be more subjective, meaning the person feels like they're eating a lot, but if we were to compare that sized meal to, another typical person's meal, it really wouldn't seem to be a lot. So for example, this person's binge might be eating like The example I always give is like a whole tray of sushi that you might get from like a grocery store or a dining hall, which is a normative amount of food, but might feel like a lot for this individual. So at this point, I would suggest pausing to watch Anorexia's living face to see Isabel as an example of a woman with anorexia. So because I know that a number of you guys are from kind of health backgrounds, or at least are kind of thinking in that direction in terms of career, we are going to talk a little bit more so about health during this lecture, because we're dealing with eating, which means that we're dealing with physical health as complications. So anorexia impacts less than 1% of females and males, although it impacts about 3 times as many females as males. So rare, but definitely very female dominant. The prevalence among teenage girls specifically, though, is 2%. So you can see that if we're kind of narrowing in on that age range, the prevalence bumps up compared to those lifetime ranges that are represented up above there. So this is going to be the highest risk kind of age group. Anorexia is also the eating disorder that has the earliest age of onset, which is specifically between the ages of 15 and 19, and again, more commonly in females compared to males. As of 2013, the amenorrhea criterion was removed from the DSM. Amenorrhea is a clinical term that means that menstruation has stopped. So this is a symptom that was obviously very specific to females versus males. And so with the removal of this, we may start to see relatively more males being diagnosed with anorexia, given that this barrier is no longer there. As far as health complications, there are a huge number of things that can go wrong as a consequence of this severe restriction that we're dealing with here. Just some examples, again, not an exhaustive list, but some examples are osteoporosis. It's pretty common to see thinning of bones in terms of their density, such that bone density can start to more closely resemble a much older person than a teenager. Starvation is also obviously a concern, because we're getting to a point where the person's not consuming enough calories to keep all of their organ systems functioning as they should, which is one of the reasons you'll start to see people with anorexia getting sick more easily. It's because their immune system has been depressed. That's also really the reason for females to lose their ability to menstruate, or for the male sperm count to decrease, is it's because those are kind of optional reproductive systems, and that, they're ideal if they're working, but the human body will ultimately survive without them in the short run. And so that's really what's happening there. But the problem, of course, is if the person continues to restrict past the body's ability to kind of cut unnecessary systems, and that's when we may start to see the person going into heart failure or entering into a coma or something like that. And so for that reason, anorexia has the highest mortality rate of any diagnosis within the DSM. There's a 5% mortality rate per decade of follow-up specifically. And the reasons for this go back to starvation, but then also the higher risk of suicide that is inherent with pretty much any DSM diagnosis. There's a 75% comorbidity rate for anorexia. And this is something that you're going to see pretty consistently throughout the eating disorders, is they're very comorbid. There's frequently other stuff going on. All 3 of the eating disorders are highly comorbid with depressive disorders, but specific to anorexia, we're more likely to see a comorbid anxiety disorder, and this typically predates anorexia, meaning that the person's developed a generalized anxiety or social anxiety or even an obsessive compulsive disorder, and that anorexia has kind of grown out of that anxiety in a way very similar to what we saw in watching that video about Stephen several weeks back. Okay, so moving right along to bulimia nervosa, or bulimia for short. So here we're dealing with a binge purge pattern, but we're going to be much more specific here as to what we're meaning by those terms. So first off, we have to define what a binge eating episode is. And this is a 2-pronged diagnosis. So the person has to be eating more food in a time period than others would. So that time period is flexible, but whether we're talking about half an hour or 2 hours or a whole day, if we're comparing what this person is taking in, it's significantly more than others would consider consuming in that amount of time. and the person has lost control in the situation, which typically means that at some point they're wanting to stop, they're wishing that they would discontinue, or even at the end of the binge that they're feeling some type of guilt or remorse over the situation. So it's not purposeful. And depending on the amount of time that we're talking about, typically we're considering anywhere between 1,000 and as many as 20,000 calories being consumed. Beyond that, though, we need to have some type of recurrent, inappropriate compensatory behavior. And so this does include purge types of behaviors like vomiting or using an Epicac or a laxative, a diuretic or an enema, or this could include other types of simple compensation, such as fasting, dieting, or excessive exercise. So the takeaway here is that we're dealing with some type of compensation basically for the binge, and that may include removing calories from the body, or it may include just limiting the calories that go into the body going forward. And so you can see if you look at these two pieces that they do really complement one another, that it makes sense that if a person has just eaten a large amount of food and they're not feeling great about it, that this could then contribute to some type of compensation. And, that's really what the name suggests, is that this is a compensation for the binge. But then what happens, and that's kind of why I have this random picture of Bear Grylls on the screen, is that when people restrict too much, whether this is through fasting or dieting or too much exercise or removing the calories from your body via vomiting or a diuretic or whatever, that you can start to make the body really, really desperate for food. And so it's kind of like, whenever you're watching a survival TV show or movie, and you've got the person who's kind of in the desert and they're searching for water and they're starting to hallucinate, and suddenly anything starts to sound good because they're so desperate. And then they find this like muddy puddle and they basically fall face first into it and, may give themselves giardia just kind of consuming whatever is there. That's kind of like what happens with the binge, is the restriction is too intense, too rigid, to the point that the person then can't really control themselves around food. And so the solution here is really a more moderate, kind of stable type of eating. And so this occurs for at least once a week for at least 3 months, but it may be more frequent. Binges may increase up to 20 times a day, which may seem a lot, but it would basically entail the person consuming largely snacks, and those snacks being large in quantity and then also very frequent as well. And then the final piece is that the person's self evaluation must be influenced by body shape and weight. So basically, their self image, how they feel about themselves, their self esteem is now being impacted by the way that their body looks. And so I don't have a video example of this one. I used to have a really great example, a male example of bulimia, and then it disappeared from YouTube. So in trying to find a replacement, I stumbled across this video, and much of the video wasn't really relevant to class, but I liked this one letter that the vlogger posted. And this is a, vegan, vegetarian kind of weightlifting channel. And so this guy is writing in, and you're welcome to kind of pause and read the whole letter if you'd like, but I've highlighted some of the more relevant pieces for class. And so this guy is writing in, he's saying that he cycles carbs, which is a practice of basically limiting one's carbohydrate intake throughout the week and then consuming carbs on a single day throughout the course of the week. So there's that pattern of kind of restriction and indulging here. So this guy cycles carbs. His main issue, though, is with the weekly refeed days. They usually turn into binges, his words, of 5 to 6,000 calories or more. So that would fit our definition as well. Fortunately, he easily diets down over the other 6 days, and the next week comes back to a pre-binge body fat percentage or less. He's tried a few times switching to a steady moderate carb diet instead of cycling, but describes himself as being kind of carbophobic. So we're seeing some anxiety there. And so ultimately fails and then comes back to the current carb cycling regime. So I like this example because it highlights this type of diet or exercising program that has been a little bit more kind of normalized in this country, where even if a person's not doing this precisely, it's definitely more normative to see these types of programs than to see like the very significant dieting that we talked about in the case of anorexia. And so I wanted to kind of show this to you so we could kind of compare and contrast what this guy is saying with the symptoms of bulimia. So let's flip back to the symptoms. So we need to see those recurrent binge eating episodes, which we're seeing. We're seeing those once a week. He describes them as binges and he gives us a definition. 5 to 6,000 calories is 2 to 3 times the number of calories a person needs to consume in a day. Um, and the guy's also clearly losing control, and that he doesn't intend for them to turn into binges, and yet they are. So we can check off that first piece. Recurrent inappropriate compensation. He uses the phrase dieting down over the course of the week, so we can assume that there is some degree of restriction or limiting with respect to what he's consuming. This is a weekly pattern, so it occurs once a week, and if we can assume this guy's been doing this for a couple months, we can check off to this third piece. So the only piece that remains is the self-evaluation piece, which if you read the rest of it, I think you could maybe make a case in either direction. It's not completely clear just based on this limited information. But my main aim in sharing this with you isn't to necessarily debate that fourth point, but to highlight how, this is really why athletes in particular are at a higher risk for eating disorders, because frequently, in order to really excel at what they're doing, they need to adjust what they're eating. And this frequently can end up setting a person up for an eating disorder because what they're eating is checking off the behavioral symptoms of the eating disorder. And so at that point, all they need to have is an emotional switch in order for them to qualify for an eating disorder. So if we go back even to anorexia and we have like a dancer who is limiting what they're eating, or a model and getting down to a very low body weight, at that point we really just need some shifts with respect to their anxiety levels and maybe their relationship with their body for them to now suddenly qualify for an eating disorder. Here we just need a person to be engaging in some pattern of restriction and indulgence regularly, and then we just need to see a shift in how they're thinking about their body and their self-esteem for them to qualify for an eating disorder. So again, my main aim in showing this isn't to necessarily debate whether this guy has an eating disorder or not, but to just kind of show how certain behaviors will put you at a significantly high risk for an eating disorder. And it's not all women either. So bulimia and health. We're going to see bulimia being diagnosed more commonly than anorexia, about 1 to 3% of females, still less than 1% of males. Most people, however, tend to be of a normal weight to overweight, and this is using the BMI kind of weight delineations. And so from this perspective, bulimia is actually more of an invisible eating disorder. You can't really look at someone and be able to gauge that they're at an unhealthy weight in the same way you can do with anorexia. There are also, of course, health complications. Most notably, we may be dealing with electrolyte imbalances as a consequence of either really limiting what the person's consuming or taking food in, but then flushing it back out very quickly through um, a diuretic or vomiting or something like that. And electrolytes are really important. They are the pieces, of our bodies, I guess, that help physiologically many organ systems to do what they need to do. So, for example, having insufficient levels of potassium can contribute to heart arrhythmias, cardiomyopathy, paralysis, tetany. Um, Deficient calcium can contribute to osteoporosis, and hyponatremia or low sodium can contribute to seizures, headaches, brain hemorrhage, or even coma. So some very significant consequences of electrolyte imbalances. And so for this reason and the health reasons I talked about earlier, it's very important that if you're treating an eating disorder, that you have mental health and physical health care providers overseeing the person's treatment. So like if I'm working with an eating disorder therapeutically, I always make sure that they are going to the doctor regularly so that their electrolyte levels can be checked, or or whatever else the physician feels needs to be done to make sure the person is healthy and that we don't need to up our level of care and potentially send that person to the hospital. In terms of comorbidity, we're again seeing about 3/4 of people with bulimia having other diagnoses. Again, notably, we may be dealing with depression, but something unique to bulimia is that we're more likely to see substance use disorders as a co-diagnosis. Bulimia may also be the most culture-bound eating disorder in that it's very modern. It doesn't have as long of a history as something like anorexia. So people born after about 1960 are at a higher risk for it compared to people born earlier. There's also a social component in that we see it diagnosed in higher rates in more urban areas where there is a stronger Western influence compared to rural areas. And then finally, last but not least, is going to be our binge eating disorder, sometimes just referred to as binge eating or BED for short. So for this diagnosis, we need to be seeing recurrent binge eating episodes, and we're going to be using the same definition that we covered earlier. So you can see the bulimia slide for that definition of a binge eating disorder. No compensatory behavior, and the binges need to be associated with at least 3 of these 5 symptoms: eating quickly, eating until uncomfortably full, eating when not hungry, eating alone out of embarrassment, or feeling disgusted, depressed, or guilty after eating. And collectively, the person has to be binging and feeling this emotional piece at least once a week for at least 3 months. At this point, I would suggest pausing to watch Robert in a first-person account of binge eating disorder. He does a really nice job of explaining how binge eating is really almost like a food addiction, only unlike um, gambling disorder or a substance use disorder that you can't completely cut food out of your life. He also describes a trauma history, indicating that, kind of like what we've talked about before, that even though, trauma is in the title of PTSD, that trauma can obviously come out, so to speak, in many different ways, one of which being an eating disorder. Binge eating is the newest eating disorder. It was added to the DSM-5 in 2013. It's the most prevalent. It impacts about 2 to 4% of adults and about 5 to 8% of obese individuals. I do find it important to point that out because one of the biggest misconceptions about binge eating is that it is synonymous with obesity and that everybody who is obese has gotten to that point through a binge eating disorder. And that is just simply not true. A fraction of people with obesity do have a binge eating disorder, but they are far from being synonymous with one another, as those prevalence numbers indicate. Health complications here are basically going to be the health complications of a Western diet. So we're going to be seeing diabetes, high blood pressure, high cholesterol, gallbladder disease, things like that. And then from a comorbidity perspective, we're again seeing 75% comorbid. We're seeing those depressive disorders. And then something unique here is that we're seeing some impulse control disorders as well, which makes sense since impulse control is really one of the things that drives binge eating disorder. I find it's interesting to look at personality with eating disorders because each of the diagnoses does have a different personality type of pattern. And so this doesn't mean that just because you are perfectionistic, for instance, that you're automatically going to get anorexia, but there do seem to be different types of people that gravitate towards different eating disorders kind of based on their personalities. And so it's more common for someone with anorexia to exhibit perfectionism, an obsession kind of type of quality, neuroticism, controlling tendencies. People with bulimia are more likely to be impulsive, disorderly, have anticipatory worry, and easily fatigued. And then binge eating disorder is more likely to describe people with less self-direction in their lives and more of an addictive type of personality. There are a number of things that can set a person up for eating disorders later on in life, and we'll explore some of the familial pieces of this in an added reading that I have set up for you guys. But a few pieces that I want to talk about here include developmental and societal factors, and we'll also talk about some precursors specific to each of the 3 diagnoses. So developmentally, if mom is dissatisfied with her own body, that can precipitate any of the eating disorders. If mom or dad has an elevated BMI, that can also precipitate an eating disorder. Societally, anytime a person internalizes the thin ideal that females more so than males are frequently getting from media and society in general, that can set up an eating disorder. So, what I mean by internalization is that when girls are young, initially this thin ideal message exists outside of them. So they may be seeing Barbie, for instance, and other kind of examples of the thin ideal, but it's something that is external to them. Whenever we internalize something, we are now accepting it as being important to us personally versus simply existing outside of us and being important to others, but maybe not necessarily important to us. So when people start to internalize ideals about the body, thin, muscular, what have you, we are seeing them at a higher risk for eating disorders. Specifically relating to anorexia, social isolation and anxiety can predate anorexia. Bulimia, interestingly enough, an earlier menarche for young females, which would be an earlier age at which a girl gets her first period, could set up bulimia. One of the reasons for this is that menstruation is one of the hallmark things that kind of kicks off puberty for girls, and other changes that come along with that phase of life, um, or weight gain, and changing shape of the body. And so basically, if a girl experiences this change younger than her peers and she feels kind of isolated or outed, so to speak, as the only one who's growing breasts or hips or growing taller or just kind of accumulating, more body fat, which is healthy, something that's a natural part of growing, she may start to concern herself with whether or not she's quote unquote fat at an earlier age. Beyond that, though, she's also going to be attracting more typically male attention from her peers and older men as well. And this can also start to make her start thinking more about being thinner, thinner, thinner. And then finally, as far as binge eating disorder goes, we're more likely to see it as a consequence of early onset obesity or early onset dieting, or any type of loss of control relating to eating. There are also some important ethnic or racial discrepancies between different groups of women and their likelihood of getting various disordered eating behaviors. So white females encompass the vast majority of anorexia cases. It's almost exclusively at this point a white female diagnosis. And the behaviors we're more likely to see from this group are restriction and purging. Black females have a much less lower likelihood of developing anorexia. One study of more than 2,000 females yielded no diagnoses of anorexia among this group. Binge eating is the more common disordered eating behavior that we will see from Black females. One of the reasons for this may not necessarily be that this group has greater body confidence, which is frequently supplied as an explanation that Black females are maybe just more comfortable in their skin, and that's why we don't see eating disorders in the same frequency. But another explanation is more of a systemic explanation in that our definitions of eating disorders are very much white types of definitions. A lot of the disorders revolve around restriction. Anorexia is kind of our oldest eating disorder, bulimia added in later, binge eating really only added in a couple years ago. And so one could hypothesize or kind of suggest that we're kind of looking at disordered eating through a white lens. So that might be why we see these things more among white women and white people in general compared to people of color. And that if we were to start looking at indicators that people of color may use to gauge whether or not they're confident in their body or not, we might start to see more issues with confidence among other groups, among color groups. So for example, skin color and hair texture can be kind of sticking points for Black women as to whether they're feeling secure with their bodies or not. And so again, kind of shifting the way we look at body confidence might reveal that in fact, women of all colors struggle with body confidence because of the Western kind of idealized culture we live in, and that eating disorders are just kind of looking at the problem from one angle and more of a white angle, as I said before. Another group that I want to focus on real quick is the Asian population. I want to point out specifically that eating disorder diagnoses may be overlooked among this group due to the petite stereotype. And I've supplied this exemplar quote to kind of illustrate, I guess, that point. So this one woman writes that many of my friends weigh less than 100 pounds and keep losing weight, yet nobody calls that anorexia because Asian women are supposed to be tiny. Doctors are subject to these stereotypes too. At my last physical, I weighed 112 pounds. The doctors were shocked as if I were fat. Okay, so moving on to treatment. Early diagnosis is key because we are dealing with significant health complications. And so we're not just gambling with mental health here, but physical as well. So it's very important to identify and treat sooner, especially that teenage girl population with anorexia, because the damage done at that age group could potentially be irreversible. And so we really want to make sure that we're identifying early and intervening. There's also, of course, that high mortality rate that comes with that diagnosis as well. So some things to kind of look for are pre-existing anxiety, those personality traits, and then if you're seeing weight change on top of that, or as we know that this group likes to camouflage, changes in the types of clothing this person's preferring to wear, those could be indicators that we're kind of heading in this direction. Weight restoration is going to be the number one concern, and this is true whether we're dealing with an outpatient or an inpatient residential unit. I do always like to point this out because sometimes when people go to these units, they're kind of disappointed that there wasn't more being done therapeutically. And this is just because weight restoration is the number one goal. And so therapy may or may not be a part of the equation, but the number one goal is to restabilize electrolyte levels, to put weight back on, and to get this person out of the danger zone from the perspective of their physical symptoms. But emotional, psychological work is definitely going to be necessary with all of these, particularly as far as those younger girls with anorexia goes. Social support and accountability are tremendously important, particularly involving the family once the person leaves to go back home. So if you're thinking about an inpatient unit, this is a unit that has a lot of structure to it. There's a lot of oversight as far as food goes. And so it becomes important to kind of collaborate with the person's family or whomever it is they're going home to make sure that we can kind of keep the progress going, so to speak. As far as binge eating disorder goes, bariatric surgery is a possibility. It should really be considered as like the last option that is considered after other forms of weight loss are considered as well. And I highlight it here because it is a surgical approach. So you guys have probably picked up on the fact that I'm trying to highlight either common psychological approaches or approaches that would be relevant to, you know, some of your majors and future careers. And so surgery is obviously a very kind of health relevant type of approach. So there are two main ways in which bariatric procedures work. They work by restricting the amount of food that a person can consume at once. You can see that there are a variety of bariatric procedures. It's not like a single type of surgery. And basically you can see that all of these are using various ways of kind of cutting the stomach or the gastrointestinal system, or using bands to tie off different parts of the system to either make the stomach smaller, which would restrict the amount that this person can eat at once, or to, in some ways, kind of slice off part of the stomach that you guys can see in this vertical sleeve approach, where the stomach almost starts to become like part of the intestinal system at that point. And so we're trying to move food through quicker in that scenario so that less is being absorbed. There are many psychological ramifications of these approaches. Depression, poor body image, and lifestyle adjustment is a big one that people don't really consider. That this is not a temporary thing that like you have done and then undone when you're good. This is permanent. So you're permanently adjusting your anatomy, which means you're never going to be able to eat like a normal sized meal again. There's certain foods that are going to be off limits, particularly carbonated beverages, which would include alcohols as well, just because there's not really space in the stomach anymore for that extra gas. An evaluation is required beforehand. So this isn't just a procedure that anybody can go get. You have to go to a psychologist first and get checked out to make sure that you're not at risk for depression, to check in with body image, to make sure that you're making good, healthy behavioral changes ahead of the surgery, and to make sure that the person really understands how life altering this is. And then counseling is also recommended afterwards as well. So this isn't kind of purely a physical health intervention, it's one that kind of entails psychological oversight as well. All right, and that is all that I have for you guys today. Thanks for joining me.